Dr. Jette is Professor and Director of Health and Disability Research Institute, Boston University School of Public Health, and co-director of the Evaluation and Dissemination Core. And Michael Friedman is Director of Rehabilitation Therapy Services at Johns Hopkins Hospital, Physical Medicine and Rehabilitation. So, welcome.
Thanks, Linda. What Mike and I thought we would do in talking about the collaboration with between myself, my group, and Hopkins is he will go first and he'll talk in detail about the evolution of the work that's going on in Hopkins, and you'll see some similarities with the model that Diane and Mary talked about at Cleveland Clinic and how this collaboration is moving forward. And then I'll come back and I'll talk a little bit about kind of my perspective of some of the challenges that we're facing with this kind of approach to health services research moving forward, and then we'll open it up for questions. So, Mike?
Thank you. I think our slides are, they're in the right order. But they're probably not in the right order in how you have them. No. So first of all, I just want to thank you so much for being invited. It's very humbling. I'll have to say 4 or 5 years ago, I didn't know many of these people. And now I will say over time, we at Johns Hopkins have collaborated with the folks at Intermountain, with the Target trial, with Cleveland Clinic. And I often say, we don't need another original idea ever. We just got to figure out how to implement it all. So I guess I now need to figure out home care and the stuff from Beata. So that'll be the next couple of years. So one thing for us, and Mary Stuff and I present often together as well, and was mentioned in that question how we work together, at least right now, informally. I think a number of health systems work together and how we're implementing best practice, and especially around how we've used 6 clicks and AMPAC in the inpatient hospital. Just this past next conference, the board approved what is the Council for Health System Physical Therapy, which will be the first formal area where the health systems will come together in a fashion to really start to work and network, and hopefully look forward to that being a nice complement for CoStar and many of the people in the audience. So let me get started on our main goal and our main vision was around interdisciplinary functional assessment and really realizing immobility as a harm. And when you talk about what Pam Duncan mentioned yesterday, I'm preaching to the choir. Many of the slides I'm going to show you are slides that I show have our president of the health system, our dean and CEO, chairs of our multiple departments. And so I want you to step out of your physical therapy background and think, if you weren't a physical therapist, where mobility and where function sits in the great bandwidth of healthcare as people are taking on so much, especially in this environment. So much like Mary starts with all the time, I need to tell my story. And so this is Johns Hopkins Medicine. The main hospital is in Baltimore, Maryland, that most people are familiar with. We do have 5 different hospitals between Baltimore and DC. All those little dots along the way are all our primary care sites that are most of them part of the Target trial. So, and we also, because it strategically makes sense for us to have a pediatric hospital in St. Petersburg, Florida, we have one down there. So this is the first slide I really show, which is just, I used to have all these slides about mobility, and I broke it down to bed rest is bad. Are there any questions? And I mean, it doesn't matter, no matter what system, and we know this. People want to exercise more. They want to sleep better. They want to eat better. But all of a sudden, someone goes in a hospital or someone's sick, and we forget all that. And then this nice little graph up at the middle, which is concept of when you stop moving, you increase comorbidity, disease, debility, and that increased costs. I mean, think about how you feel after you've had the flu for 3 days and then try to get up and go to work after 3 days about being in bed or not moving as well. You're sluggish, you're slow. What does an 86-year-old feel like after a bout of pneumonia? And so what happened in about 2010-ish for a lot of us was healthcare reform came through. And what I found myself was getting invited to a lot more task forces than I ever had been before at Hopkins Hospital and Hopkins Medicine. And what I found myself in all these meetings doing was repeating myself. And I was just saying over and over again that we need to find a way to consider function and get our patients moving. And these are a number of the different initiatives. I'm sure many hospital systems have these same things. Readmissions and length of stay have always been huge. Choosing wisely and allocating your resources appropriately. There have been innovations in the ICU. Home and ambulatory care, we hear all the time that things are shifting to home and ambulatory care. But the reality is, I can tell you, our hospital is the highest occupancy it's ever been at. We have the highest complexity of patients we've ever had. So there are no shortage of patients coming into the hospital. They're just more sick, they are more frail, and they are more costly, and they are more at risk for multiple complications. And so this really started from our first question, our catalyst in 2008 was the ICU. I'm going to talk about functional assessment, but much like Mary talked about, I'm going to do this in 10, 15 minutes. We have a whole course on how you implement this and how you do a quality improvement approach to implementing hospital mobility. But when we implemented in the ICU, we found that by increasing therapy services daily, reduced length of stay, reduced dementia, and saved about $4 million to our medical ICU. It was that last part that got us funding for quality improvement personnel, physical therapists, rehabilitation technicians, and other resources necessary. And so we asked ourselves, well, what's the problem? If we can move the sickest of the sick, why can't we move the rest of the patients in the hospital? And the reality is because it's more diffuse. The patient's responsibilities are more across multiple people. There's no distinct measure for mobility like there is for falls, pressure ulcers, other harms. And so like we do in everything at Hopkins is we use this process. It's the translating research into practice model for quality improvement. And I show this at every talk we do, but whether it's bloodstream infection, mobilization of patients, or our revenue cycle, we look at this type of concept. And what it really came down to us is identifying local barriers of implementation and measuring performance. Back to how are we truly aware of how patients were moving or not? And so this was our vision. Our vision was that if a patient, we would have a real baseline. Right now, everyone's baseline of a patient before they come into the hospital is subjective. It's true in an ambulatory setting also. Imagine asking someone their subjective blood pressure. So how do we get to that, where we truly know where someone was functioning? And then throughout their acute stay, we would see a trajectory, and then we would see what happened in home care. We could see what happened in ambulatory. But if you erase the bottom axis there, that could be anything, right? Those could be ambulatory visits. Those could be primary care visits every 6 months, every year, every 5 years. But right now we have no function, and this is used a little cliche, but function as a vital sign. We're really not following people longitudinally. And so what it really came down for us is how important is function? And what we know is this. We know in the hospital if a patient misses a medication, safety alerts will go off. We will have to fill out all types of forms. If a patient falls, the same thing will happen. If a patient didn't move for 3 days, would anyone know? Probably not. And so the question is why? Was it awareness? Was it there were too many things going on? Were we not loud enough about it? What was the accountability? Were there incentives? And so when readmissions came apart, we looked into the charts to really look at this. And in our first 37 charts on a unit that we looked at, there was zero consistent documentation of how patients were moving from non-therapists. And even amongst physical therapists and occupational therapists, the measures were all over the board. And so here's the problem. We're all talking different languages. We're not really communicating, and everyone, I think a number of people have mentioned today, all the different outcome measures and tools, and there's no need to add another tool. And you'll see later I'm blatantly hypocritical because we have a Johns Hopkins highest level mobility tool, but still, we needed to get everyone on the same page, at least within our own house, on how we were going to describe function. And so this was one of the more recent Michael Porter perspectives, which really talks about minimum data sets and really getting to a place where we need to standardize those data sets and those measures nationally and globally to truly be able to communicate. But at least for us, we felt we needed to start with this in our own backyard, and our starting spot was in the hospital because we had done so much in the ICUs. Other people, it might be in the ambulatory setting, it might be musculoskeletal, it might be primary care. And so this was our strategy, was really to build the pyramid. We needed buy-in from the people who are actually going to document beyond therapies, physicians and nurses, mostly nurses. We needed to build that into workflow and understand workflow. We need to integrate it in communication. We actually had to use this language and use these numbers to demonstrate at the patient bedside what was going on with the patient. We had to demonstrate value of using those assessments, and then we had to re-engage everyone as to that value. And so I think this gets to the concept of CoStar, but we realized we were lacking a few things to get there. And there was a relationship between what I'll call the clinical operator, or people like myself and Mary. We have academic resources, but they weren't necessarily aimed and moving in the same direction. We also recognized that we really had to engage our informatics and analytics people as well as biostatistics. And when we were able to get those folks together, truly get behind a vision, and with the appropriate scientific rigor and publish some of this information, we were really able to get a groundswell. But what became even more interesting was the funding potential. Because on one side, we were looking at whether it be large grants or small grants from the academic community. That was great. But on the clinical operations, we were looking at cost savings and quality improvement, internal funding mechanisms that were also potentially available. We've developed over the last 5 years 12 multidisciplinary residencies in PTOT and speech, and within those forums, we have 10 hours of protected time for quality improvement. We strategically align them with the projects like these, so they are part of the team. We also look at partnering universities for which we take clinical affiliations, and our expectation for a clinical affiliation is a partnership around some of these types of skill sets that we don't have in-house. We also work with our own faculty at Johns Hopkins, but we do not have a physical therapy school. We don't have an occupational therapy school, but we work with other departments as well as the PM&R department quite a bit. And so the first thing for buy-in was really getting nursing to buy in. And so how do you do that? I know more about nursing documentation than anyone in this room. We had to go in line by line, place by place, and say, what are you documenting now? And get rid of things. We went into our systems and then looked at leverage points, like care coordination and readmissions was a new requirement for us. The CMS conditions of participation for discharge, meaningful use, these are all requirements of nursing that we were actually able to meet with the AMPAC activity inpatient short form, because nurses had to assess ADLs prior to discharge. And so that was an opportunity to meet a requirement with a known scale. We also were going through an EMR transition. At the same time, PTOTG codes came into play, and AMPAC inpatient meets requirements for that from an easy compliance standpoint. So there were a lot of easy ways to get buy-in right off the front. So then we had to attack barriers. And we did this in a very methodical way. We have a barrier survey that we've put together for nurses on, are you interested in mobility? What are your chief issues? And off that barrier survey, we worked with administration. Basic things like, to mobilize patients, we need chairs. Yes, you do. So we worked with administration to buy chairs. We also, one of the major things that comes up is always reliability and validity. Now, for this crowd, I know you all know what that means, but there are a number of people who really don't know what that means, and they bring that up because they just don't want to change. And so, but we did the work. We did the work on reliability with nurse to nurse, and if they could do and they could assess doing the AMPAC, as well as nurse to therapist, and it came back at a high level. And so we feel very comfortable with nurses using the AMPAC inpatient short form for mobility, as well as therapists using the Johns Hopkins highest level mobility. We also looked at feasibility during the same time to mobilize and time to document. Back to resources of doing the feasibility and reliability, our residents and our fellows in our physical therapy programs were big parts of helping make those studies happen. And so we developed a workflow and put this into place. And it became policy across Johns Hopkins Hospital. So that's 33 inpatient units It's a 1,000-bed hospital. And there are specific workflows for OBGYN, psychiatry, inpatient rehab, and pediatrics. People ask me all the time, why did you decide on certain frequencies? Why did you decide on certain elements? We picked Monday, Wednesday, and Friday because the nurses felt if they did it on regular days, they were going to do it every Monday, Wednesday, and Friday. I told them, I think you're doing it too much. They said, we want to do it every Monday, Wednesday, Friday, because then we won't miss data points, and we can hold people accountable. Why did we pick that we're going to mobilize people 3 times a day? It made sense that at home, most people would get up for at least 3 meals a day, and that should be our goal. And let's start somewhere. There was nowhere in the literature that really told us what a goal should be. So we looked for 3 episodes of mobility a day and for that to be documented. So this is the Johns Hopkins highest level mobility scale that we've developed. This is based off of a scale we use in the ICU. And it's pretty standard. I think many of you who have seen or worked within an inpatient environment have some progression of mobility that occurs. But the big deal for us was our nurse techs and anyone could do this scale on the floor. So it didn't just have to be nurses because it's an observation, not an assessment. So as you can bring measurement tools more to the front lines, you enable for greater assessment with less training, as mentioned before. We were able to really engage more people in mobility. And we often use the patient case you see on the scale. We discuss the scores throughout days, and for us at Hopkins Hospital, if you see a 3-day change in your JH-HLM, that's worthy of bringing up in rounds. And so to get people to actually use this information, we integrated this into communication. So we do this in rounds. It's at MD, at nursing reports. It's part of interdisciplinary care. So if you don't have the AMPAC score or you don't have the JH, it's part of the script. So there's in-person accountability right there to perform and complete the measure. Also within EPIC, we now have developed goals. Our language is the same around protocols. So previously, a total hip replacement would say something like out of bed, edge of bed, 50 different synonyms for getting out of bed. We now use the number system. So everything reinforces the measures. And we're also using AMPAC for AMPAC-driven discharge planning, similar to the Cleveland Clinic. And so something the nurse informatics director at Hopkins said to me, which really stuck and really sticks to this day, is if we're going to collect a number, someone better tell me what we're going to do with that number. And so it's one thing amongst our therapists where we're trying to get a certain number of therapists together. And I think I want to say Mary at Cleveland Clinic has 700 some. But when you start multiplying that times nurses and physicians, you go up into 5,000 some people very quickly, trying to implement something that they're not necessarily experts in. And so you need to demonstrate value to get buy-in. So we use some very simple rules with the help of Alan on when they should consider a change in AMPAC or in JHLM to be action. And the action at this point was to say, this person is at risk, they have changed, we need to consider their medical state, or we need a formal mobility plan. And so the biggest area where our academic group came into play was taking all this information, this workflow, and help us drive culture and accountability through the use of data. And so to start with, we just needed to show nursing units that they were compliant to their documentation using functional scales. And so we're able to show whether they did it 3 times or 2 times daily. We can actually break this down to an individual nurse and to an individual unit. And so we can drive accountability measures from directors of nursing to nurse managers to individual nurses on if they are documenting function. With our quality improvement study, again, using the data and demonstrating value, we were able to demonstrate once we put systems into place in that workflow, patients ambulating on a daily basis increased from 43% to 70%. Length of stay reduced 0.4 days for all patients, but the big deal for us were at-risk patients at 7 days length of stay, demonstrated a reduction of 1.1 days. And so that 6 to 7 day length of stay now for us on medicine patients is a big marker. And we're now looking at our surgery patients, especially with longer length of stay like transplants and patients with complications. And we also saw that falls did not increase during this study. That was the biggest concern. I always tell people what's the best way not to fall is not to move. And so we had to break that myth because at some point you're picking between harms. Are we not going to move or are we not going to fall? So we use data in a lot of other interesting ways. Call bells. How often were call bells being, how long was the call bell being used? And we saw that patients that were of higher mobility hit the call bell less. This was like the holy grail for our nurses. So that's huge. You can see that patients at a certain level of no mobility are not hitting the call bell, and we know that those patients were sedated. So that does make sense on the curve. Oh, sorry. Similar to Cleveland Clinic, we also have a workflow because nurses are doing AMPACs. We can see patients that I always say are the 24 raw scores. This means they're going down the subway and getting a sandwich by themselves, but they still get consulted for physical therapy. So why are we going up to see them? Well, now nurses are doing, they're able to mobilize those patients, and they're canceling out PT consults before we even get to the unit. So we were able to reduce our consultations to the point where we're increasing our visits per patients that are more ill and sick, close to about a visit per patient, which is a big deal. And then this is where we're going, and just we've been lucky to work with Alan, but we're now looking at different AMPAC short forms that will work within our ambulatory setting as we look at pre-surgical interventions and post-surgical interventions. We've looked at the relationship between AMPAC and our HLM scale so that we can now develop, based on an AMPAC score, we can develop a goal for a patient. And if they achieve that goal, we've seen reductions in likelihood for readmission and reduction in length of stay. We're starting to use our infrared technology in the hospital, look at overall activity and how that relates to mobility plans and goal setting on HLM, all towards this middle concept of identifying patients, sustaining a function as a vital sign, and identifying patients at risk. So I just want to thank everyone, but the big thing I always like to pull people's attention to is this took a lot of people to make happen, but the biggest thing is look at the initials between all the names up there. And it's a lot of different disciplines. And I do think as physical therapy and rehab professionals, we play a huge role in advocating for function, but we really need to understand how all the disciplines can help us get there. And most importantly, how we can get data translated so it can be used as the bedside. And that's been our biggest push. Alan?
Thanks, Mike. I want to share a few thoughts, primarily on the models that Mary and Diane and Mike have described, because I think there's some real lessons and things to think about in moving forward. And I also like to comment a little bit about where I think CoStar might be able to fit in. First of all, one comment I'd like to make is Mary and Mike make it sound easy, and it's not. I mean, they're very effective, what I refer to as positive deviance, and really affecting systems change within their organizations. And they've been incredibly effective, and they do make it look a lot easier than it is. And I do remember my first visit to Hopkins, Mike took me into a meeting with all the heads of nursing when he was trying to get them to get on board about using standardized approaches to collecting functional information. I thought they were going to throw him out of the room. He makes it sound like he really had an easy time winning them over, but he didn't. They were very resistant early on, but he was persistent, and he has a lot of credibility within the organization that he had to use to really move them to the point that they are today. And you know what's going on in those institutions, as well as some of the others that have been discussed today is really what Atul Gawande has been talking about in systems thinking. And we've seen it in example after example of how our colleagues are using data to answer really important questions at a systems level, not just at an individual patient level. And I think that's what's really exciting about some of the health services work that's been illustrated today. So I think we're making great progress on getting interested in data, learning how to use data to answer really important questions. I have to say, though, there are several challenges that I think we still have to overcome, and I just want to focus on a couple of them. And the first is, and several people have mentioned this, and Pam did last night in true Pam fashion. She said we need to no longer develop any measurement instruments anymore. As a measurement development guy, I'm a little defensive about that claim. I wouldn't go quite that far, but I do think we have to get to the point where we standardize, as Mike said in his comments and made reference to the recent article by Porter. If we're going to make change at a large scale, which is that third point in Goande's model of disseminating on a large scale, we're going to have to standardize. And I have great hopes in the registry that APTA is developing that I think will hopefully provide a platform where we can begin to aggregate data from standardized instruments across the wide range of institutions. As Mary mentioned, over 300 hospital networks are now using the AM-PAC instrument, just to take one example. But no one is putting those data together to answer important questions at a much larger scale. But if we can achieve standardization, then we can begin to really devise solutions to problems that we're facing on a much larger scale than what we're hearing today. Today we're hearing about some very exciting innovations that are occurring in institutions, but we've not heard anything about dissemination on a very large scale. We're not there yet. And I think that's where we need to go. And so I just want to spend a few moments in talking about how we might be able to do that and the role that CoStar might play. Berwick has written a lot about this. Don Berwick used to be the directors of the Centers of Medicare and Medicaid for a while until the Senate refused to appoint him as a permanent director. And he's also started the Institution for Healthcare Improvement, and he has been doing this breakthrough collaborative series for many years now. And he has argued in many different writings that he's acknowledged that invention or innovation is really hard, but the point he keeps making for us is that dissemination on a large scale is even harder. Now, Tony argued earlier today that pragmatic trials might really help us disseminate much more quickly and much more effectively. I hope he's right. I must admit, though, I'm a bit more skeptical. My fear is that, let's say, for example, Tony and Pam's trials are effective. My guess is the institutions who are involved in those trials will adopt the innovation. My fear is that it may not spread very widely beyond that, even though the pragmatic trial is really designed to be much more generalizable. I think there are a lot of challenges to really achieving large-scale innovation and dissemination. And what Berwick argues is that we need coordinated deployment of practice innovations. And I think we could do that, and I think CoStar could help accomplish that in the coming years. I have argued in a recent editorial in the journal Physical Therapy that what we need is something akin to what Dartmouth started, I think back in 2009. They had started a high-value healthcare collaborative, which was a voluntary coming together of medical centers, 5 initially, who were interested in asking important systems questions and trying to get answers that they could then disseminate within that collaborative. I haven't seen anything like that yet in rehabilitation, and I think we have the people in this room, for example, who could become the nucleus of a high-value rehabilitation care collaborative. If you look at the work that the Dartmouth network has done, they're very medical in their orientation. And in fact, if you look at their very first publication on total knee replacement, their whole focus was on what happens within the surgery and within the inpatient hospital phase. Nothing about what happens once they left the hospital. So I think there's a tremendous opportunity of coming together across systems, using common measures, agreeing what are important questions so we can begin to work together on a much larger scale to address really important systems questions, many of which were illustrated today in the outstanding work that people are already doing. But I envision doing it on a much larger scale. And I would love to see CoStar help provide a forum for people to come together, and maybe the registry, the APTA registry, providing the platform for the coalition to work together and to bring the data together so that we can begin to answer much larger questions on a much grander scale to achieve much faster dissemination. So I'll leave my comments there, and then we can open it up for any questions or comments that you might have for Mike and myself. Thank you.
So, Alan, I think my question's for you, picking up on this last point. So it's really intriguing, this idea of a high-value collaborative. What I hear you talking about in terms of, and others talking about in terms of consolidating data, sounds like what I hear when I hear people talk about PecorNet. Is there, I know that arranges the players differently, but is this intersecting with that particular infrastructure in any way that could be potentially useful for this conversation?
I don't know, Julie. I don't know. I think it's an interesting question, but I don't know.
So a comment and a sort of a broad question that maybe goes to more of the audience as a whole. But Mike, what amazing stuff that you're doing. I've been hearing about it, but to see it is really impressive. So just congratulations and let's talk. But that leads to, I heard it yesterday in the advisory board meeting, and you mentioned it, I think, Mike, today, that APTA has this, and I wrote it down, sort of a health systems council. And so I'm interested to make sure that we think about it as a community health systems model and not just bricks and mortar. So just a commentary. Because it sounds like it's large health systems, the group that's here in many cases, getting together and collaborating, but there are a lot of us that are out in the community that are, how do we make those connections? And I know it's not, you don't have the power over that, and I'm just hearing about it, so I'll follow up. But right. If it's about connecting, I think there's an opportunity there.
So first of all, let's be clear, I have zero power. I don't know. There is a CEO of the APTA back there, but I'll mention a couple things that I think, just to give you some history. A long time ago, 5 or 6 years ago, myself and Mary Stilfen, Julie Hobbs at the time from Mayo, were trying to find a place where we could convene with each other. We were leaders of health systems, quite honestly, looking through U.S. News World Report, trying to figure out who to talk to each other, mostly about our electronic medical records and transition to perhaps Epic or whatever it was going to be. And there was nowhere for that conversation to happen. I can't belong to 16 sections of the APTA. We weren't necessarily an academic group. Beyond academics, our incentives were more operational, honestly. And so we just started talking amongst ourselves. It was helpful at the time that the president of the APTA was also a person who worked within a health system, being Paul Rocker. And he tried to find us a spot where we could start to convene. That was 5 years ago or so. We added some people along the way that have convened we were in our own little small group, I'll call it a shadow organization, of Intermountain, Stephen Hunter, the folks at UPMC, Providence, and Kathy Zirazinski. All these people that have been bringing forward these innovative models, we met them. And we were able to kind of share models amongst ourselves, but never really bring it to scale. Now, when we talked about systems, it was a cross setting. So all of us had some oversight or relationship with inpatient, ambulatory, post-acute. And so we had this vision of, and not necessarily discipline specific either. And so I think the concept of how to fit within the APTA, or quite honestly outside the APTA, is how do you create these networks? And this at least creates a opportunity for a certain other group to get together and find those appropriate interfaces. Those interfaces might be with HPA, and we've talked with HPA. It might be with the home health, it might be with private practice, it might be other groups that we work with, but the concept is to be very inclusive. But honestly, previously there was no home for pretty influential healthcare organizations. I mean, that the American Physical, and I'll go out with the CEO in the room, I'll go on the limb to say, for there not to be a home for Johns Hopkins, Cleveland Clinic, UPMC, Cedars-Sinai, Mass General to get together and share best practice is unfortunate, because I think there's an opportunity with just sharing what each of those organizations does best for some of the dissemination that Alan's talking about. So that's the concept, and it is very much open. And if there are opportunities for people to engage with groups like ours, that's our interest is practice. It's close to a break, Alan. Just saying.
I'm intrigued by Julie's comment about PCORnet, and I don't want to start by all the barriers, but clearly one of the issues, the challenges we have is the fragmentation and the lack of integration, throughout everything we deliver. I mean, we're still this cottage industry out there, and that even makes standardization, the degree of difficulty of standardization, even greater, because you're an integrated system, Mike, and look at the problem you had of getting standardization across the board, and we sort of have the same issues. It's almost insurmountable when you think about the fragmentation of the rehab profession as a whole, all the rehab professions as a whole. And it really does bring the issue of PCORnet could work if and only if there was an acceptance of standardization. It seems to be the number one issue before you can move any further along. And I don't know if you have insight as to what that's going to take, because I mean we've been saying this a long time. The people that are in the research side of things always appreciated standard. It doesn't seem as though that's something that's appreciated throughout.
I can only give you my biased view on what it's going to take. And I'll tell a story about when, I think, Gerard, you and I were meeting with MedPAC several years ago around issues of what assessments should be used to look at function in post-acute care, because CMS was moving towards a more integrated approach to looking across the episode of post-acute care. And they came to the experts and they said, tell us what instruments to use and we'll consider adopting them. And I'll never forget, APTA was represented in that room. There were several others of us from the physical therapy profession, and nobody would take a stand on using a standardized approach. And so CMS was willing to do it. They were asking us to tell them what to use, and they would standardize and go forward in using an approach, and we would not do it. So, we've met the enemy, and they are us. Even with the APTA registry, as Jay talked about today, there is no standardized measure of function in the registry at this point, if I heard you correctly. So I think it was Gerard who made the point earlier, start small, then go big. So I think you start small with a small network of like-minded people who are willing to standardize. That's what the Dartmouth group did. It was volunteer, 5 institutions, and now it's in the 20s, some, and they're using standardized measures of the areas that they're interested in. So I think if you can get 5 institutions, 5 networks to agree on standardized measures to ask important questions, then go from there. So start small, go big.
I just, Tony, to your point, I think one thing that's hard for rehabilitation is we're a horizontal service line across many verticals. And in some of the industries we've worked closer with, like orthopedics, maybe we have come to guidelines or we've come to relationship with their registries or with the outcome measures they're using. And so working with some of the orthopedic surgeons or working with those drivers or those incentives they have for their outcome measures, for us to just drive functional measures, we all need to manage the sensitivities, politics, and players in our own organizations. You start to move into neurology, other diagnostic specific areas, it becomes even more complex as you increase the number of players. Pain, it increases. I think the one area that's really open, where I found was really open, was composite function or composite activity. No one really is talking at it this. It's a little dirtier, it's not as condition specific, but it's an opportunity that at least for us, once we put the infrastructure in there, we found all the other departments gravitated towards it because it was something that was built, it was in the EMR, data was accessible, and they could start to do things. Now, whether that's AMPAC, whether that's PROMIS, whether that's other measures, I think the tools might change, but the concept of strategy is similar. I do find it's very challenging at the diagnosis-specific measure front to get to yes in our own organization, let alone across multiple organizations.
So I've been doing this for about as long as Alan has, and I've never had any great interest in having the more XYZ scale. It's completely irrelevant to me. As long as it's standardized, then you can actually use it. As this today, listening to the various systems, the greatest benefit has come from actually the simplest measures of mobility, the simplest measures of self-care. And if you can have a simple measure that works across, then it's very easy to let the neurologists have what they have, the have what they have. That's very fine for the subset, but you must have a common language framework across. There is some hope that if you're dealing with a common language framework, behind the door, you could have all this statistical mumbo jumbo that could actually equilibrate them, and they work very, very well when you actually do that across the global. But you can't do the neurology measure and the shoulder measure and think they're going to be the same.
Yeah, I think
I think everybody knows that. But the power of a common frame is just huge.
Our approach, and this is one organization's approach, is we had a similar, I think UPMC mentioned, an outcomes summit amongst our space, and we decided our composite measures, we were going to use the AMPAC scale as composite, and we decided in each diagnostic specialty what we would choose, and we chose, and we didn't look far. We looked at Intermountain and saw what Intermountain was doing over orthopedics and said, if we're going to choose something, we should choose something another organization is using so we have some comparison down the road. And so once we got to diagnostic components like cancer, like neurology, that's what we did. And we also looked at the different academies and the drivers of some of the registries for some of the surgeons or other physicians to make sure they were part of the conversation. Because if you're picking your strategy, we might as well start off with an interdisciplinary look.
And Vince, your presentation earlier today was a perfect illustration of the power of a common language. And people have criticized the MDS for many years. Nonetheless, the power of what you've been able to do because of its existence is impressive. And Ken made reference to the functional independence measure. And if you look at the literature in inpatient rehab over the years because of its universal use, also we have learned a tremendous amount. And that too has been widely criticized for a variety of reasons. So a common measure, no matter which one it is, will be roundly criticized. I mean, that's guaranteed. But in the end, I think much more can be gained. And if we don't eventually get there, then I think it's really going to hold us back.
An infrared system that you were doing for mobility, and I'm wondering, does that give you interval data, and have you looked at that relationship between that and your ordinal scales?
So we're getting there. Mostly that was a reaction out of every company with a wearable device and an application right now has my phone number, and none of them integrate with Epic. And so one of the challenges as we look at remote monitoring and what we need to do in the future, which is I think we need to get there, is a solution around that. For us, the technology that we have is we have infrared monitors that actually track our equipment and some of the transport of patients that goes on in the hospital. And so we're using that technology, and if we put those same infrared badges on patients, and there's a button on there as well that can, if it's clicked, we can tell if they're in and out of bed, and we can do timestamp, we can do gait speed. And there are still some work on the algorithms that we need to work on, but it does allow enough coverage from node to node that we should be able to see people's activity within a day, within reason, and would still be better than anything we have now. We have done work with other items like accelerometers in the inpatient area, and there are challenges in feasibility with infection control, loss, replacement, and so those are a lot of the things you need to think about. And at what point does precise measurement not change clinical practice and cost and logistics and feasibility? So that's where we are. But we have great hope for the infrared technology. The other technology is there's technology on the beds themselves that can start to tell us when patients are in the bed and not. So we're working on the algorithms behind that that really tells us that patients are up and moving.
Thanks. Thank you for all the presentations today. They've all been very inspiring, and to see the energy of physical therapists and how they're changing models of care. But I couldn't help but add 2 cents to some of the work that Vince started in terms of the MDS, and just mentioned that Intri has continued to develop instruments. And I'm not sure how it might fit together, but I just wanted people to be aware. I was talking to someone the other day of saying that, in fact, our instruments now go from children to people with intellectual disabilities, to community health with different modules, to acute care, and actually a nursing admission assessment. And of course, we've moved past the MDS 3.0. We have an intra-LTCF and post-acute care, different ones. They're a bit shorter now. But it is a system. And so I just wanted people to be aware and how people are using this in various countries, like New Zealand or Belgium, where people can log onto the web and see what the previous assessments were, done by people not within necessarily the same organization, but in a different setting. I just think it might, just knowing that these instruments are available, and some for ambulatory care as well, I'm not sure how it comes together, but I think clever minds might be able to look at that. So all these assessments share common items across these settings. They're not all the same. And mental health has some specific mental health instrument assessment items. But where there are core items, they could follow patients or children with disabilities all the way through old age. So that is one of my passions, this integrated healthcare system. But it's interesting to think of how it might also fit and meet the requirements of rehabilitation, given that we work across all these various settings as well. So knowing they're out there and they could be used or sold to your institutions or your managed care organizations is something that follows patients over time. Anyway, I just wanted to mention, because I've heard a lot today, I'll tell you one concern I have as a clinical operator, and I've heard a lot about large data sets, I've heard a lot about pragmatic trials, and I think the pragmatic trials are the furthest along in this, at the beginning, Pam Duncan spoke about how much time it will take to translate evidence into practice. And I just see with sensor data, just look at all the pieces of equipment in a typical outpatient gym that have some readout that cannot be integrated into the electronic medical record or cannot add value at all to a therapist treatment.
I'm concerned that the next translation issue we will have is translating data into clinical practice and clinical decision-making and patients at risk. And so I guess I have a platform with a lot of people who are health services researchers, and I know there are a couple clinical operators out there, but would just ask as you define your questions and what you seek to do to really think about how that data and how that question is going to be translated in the workflow to actually impact care at the bedside and in the EMR. And so I just wanted to throw that one out there as an audience member. That's been something that's kind of been playing through my head.
So just to follow up on that, now when we write grants, we're actually required to explain exactly that, how we're going to do that. That's a relatively newer way that we're being judged as the merit of our work. So people have heard that message.
Thank you.
Any other questions or comments before we take a break? Yes.
So I'm interested in, I know that Johns Hopkins has a specific fall risk assessment screening tool that the nurses use, and I'm interested if you've done any work with the JHHLM, and because it seems to me, let's just use one scale as opposed to two, the relationship between the mobility scale and fall risk assessment.
It's easier said than done, right? We looked at we looked at a nurse admission. An admission to a patient and all the questions a nurse needs to ask. And not just the fall scale, but also what they need to do to assess pressure ulcer, readmission risk, the Rankin scale, and the number of repetitive questions to meet core requirements for measures, safe patient handling. They all repeat, and what's really hard is because of how, and I point to other experts in the group here, but how either how the questions are posed or in specific language, you just can't simply put them all into one questionnaire and they give you the same score. So for us, putting together the Johns Hopkins fall assessment and the highest level of mobility scale, they just come out of two completely different methodologies. We do talk to our falls people regularly and are trying to always get down to what's the minimum amount of documentation and work effort time we can do. And sometimes we just lose battles. And right now that's a losing one.
But you haven't even looked for correlation between HLM and...
I'd have to ask. Dr. Eric Hoyer does a lot of that work. And I know we looked at falls, but we did not necessarily look at the scale specifically. We work very closely with the people who deployed that scale and falls, and I'm sure it's on the list, but not directly yet. It's a well-used scale. It's out in quite a number of hospitals, the falls risk assessment.
Thank you.